Thank you for having me and welcome all. I'm going to try to tackle a rather complex topic of how the brain is affected by HIV. My name is Dr. Gaultier. I'm here from Cedars-Sinai and UCLA system for the past 30-something years. And I am thrilled to be here at Eisenhower to continue to do what I love, which is HIV care and taking care of my community. Let me see. So we're going to talk about the effects of HIV on the brain prior to the advent of medications to treat HIV, and try to determine who is at risk for what we call H.A.N.D. And that stands for HIV-associated neurocognitive disorder, which is kind of a mouthful. H.A.N.D is a lot easier to use, and I will use that for this presentation. It turns out that, not surprisingly, older people living with HIV are the highest risk for cognitive impairment because of the natural progression of aging on chromosomes in particular, and HIV unfortunately compounds that. As you can see, you see more and more H.A.N.D as you get over the age of 50, and almost 50% of people living with HIV will have some degree of mild cognitive impairment, which is sometimes too subtle to discern, which is good. In recent studies, they've looked at the patients getting diagnosed older in age and living for many years with HIV without treatment, and finding that they were having much more effects on the brain, and dementia was much earlier to set in, as this slide illustrates. So how do we do prevention for H.A.N.D? And that is usually something you need to still look at in older people, as I mentioned, but curiously in heterosexual patients, English as a second language, lower socioeconomic status, and underlying anxiety, depression compounds the effect of HIV on the brain. As I mentioned, almost 40% of patients will have some degree of impairment, despite being fully undetectable in the blood. And that is possibly because we now understand that not all antivirals work well and get into the brain. And sometimes you develop a little bit of a breakthrough infection in the brain. And I'll talk about that a little more. So this is a complicated slide, but I will just point out to the pretty colors on the graph, and the HIV tends to affect different part of the brains unevenly. And if you look at the cerebellum, which is the back part of your brain that controls balance and fine coordination, you find that in the red line, untreated patients for HIV will continue to lose brain tissue. And with treatment, you can correct that to some extent. And then same thing in the thalamus, which is another esoteric part. And these are studies that were done before we had HIV therapy. Another illustration, different parts of the brain, the right temporal lobe, before antiviral therapy on the left and after therapy on the right. You can see a fairly dramatic effect on the right. The red line going down fairly dramatically in the course of about 5 years. And with therapy, the blue line, you're able to hold on to the brain. So one of the things that has been curious is that with the advent of therapy, before we had HIV drugs, so before 1987, almost 50% of patients had no impairment. About 30–40% had mild H.A.N.D or HIV-associated dementia. Mild neurocognitive impairment was in the orange, and in the green was asymptomatic. People don't know. With antiviral therapy, you see that the 50% mark is actually a little more pronounced. The amount of dementia is much less. The mild category is actually a little higher, and then the asymptomatic is actually higher. And so we feel that it's a greatly underappreciated issue, and there's a lot of research going on the topic. So what have we learned over the years is that basically you need to treat the HIV 100% of the time. Don't take breaks, don't take vacations, don't take holidays, don't take a year off. All of that is associated with further loss of brain function and potentially compounding cognitive issues. Achieving undetectable viral load actually helps a lot. Studies looking at spinal fluid and viral load in spinal fluid found that there's a great deal of concordance, which means that the viral load is undetectable in the brain and in the blood. But as I mentioned, not all medications for HIV are created equal. In one particular drug called tenofovir, which used to be called Variad, or is now called Vemlidy or TAF, which is part of Descovy. So tenofovir is part of Truvada and TAF is part of Descovy. Those two compounds do not get into the brain at all. And that may be a good thing, and I'll talk about that in a minute. Some drugs, some of the older drugs that we used to have, such as AZT and the Veramune, both get into the brain very, very well. The problems that we found that in laboratory testing, that was actually affecting the nerve cells and causing some toxicity. Abacavir similarly also gets into the brain well and can cause some toxicity, as was found in some laboratory testing. So what is the damage caused by these drugs when it gets into the brain? And this is a long list of things, and basically we'll keep it simple and just say the nerve cell tend to shrink, and then the chromosomes tend to shrink with age, but there's a little ditty on the end of each of our chromosome called telomeres, and some of these drugs actually cause shortening of the telomeres, which sort of accelerates aging, and aging of the brain in particular. Some of the drugs that have been found to be very good at getting into the brain and cause no toxicity and actually cause and actually improve memory have been things like darunavir, called Persista, FTC, which is part of the Truvada or the Descovy, is very similar to 3TC, Epivir, and then Maraviroc, called Cellzentry, which is now generic, has actually been associated with improving memory and reconnecting memory, which is there. The feeling is that the memory is affected by a disconnect of the different memories and trouble linking the different events so that you can remember, so to speak. All right, what about the chromosomes in the brain? So as I mentioned, you know, as we get older, our chromosome gets smaller because the telomeres, which are these little things on the end of your chromosomes, are there to add DNA to the ends of the telomeres so that your chromosomes stay longer. And I think there's some rejuvenation clinics out there who will sell you compounds to increase your telomeres and measure your telomeres, and you can agonize about the details of it. The study, unfortunately, is a little murky because if we looked at 3 studies that looked at the effect on the chromosomes, in a Swiss cohort, which is a national health system, for 17 years, they showed a clear benefit of HIV therapy and noticing that there was no further shortening of the chromosomes, which is very reassuring. And no specific drug caused any shortening. But the Swiss cohort is a smaller group of patients. In 2 other studies that were presented at a meeting a couple of years ago, they showed that the tenofovir, the Variad, and the Descovy part do impair this enzyme, the telomerase. And conflicting data is that the tenofovir in the first study blocked the enzyme, but when it was redone in 2022, it did not. But the tenofovir alafenamide, the new version, the Descovy, actually did block the enzyme. So there's some dissension and some inconsistency. But as I mentioned, this may not be significant because these drugs do not get into the brain almost at all. So the effect on the brain is not going to be very important on the rest of the body, perhaps, but not on the brain. And these are the references that I can make available. So this is a little more esoteric analysis that was done in looking at the actual toxicity of each of the HIV drugs. And this is probably about 10 years ago because some of the drugs are older. And they looked at the toxicity index of HIV meds on nerve cells. And the ones with the arrows are the drugs that were associated with the most damage to the nerve cells. And on the left, the nucleosides abacavir, which is part of Zygen or Epsicom, and DDI, if those of you who remember the sort of minty powder, minty fish powder. And then finally, efavirenz, which is Sustiva, nevirapine, which is Viramune, etravirine is Intelence, atazanavir is Reataz, and emprenavir is Lexiva. A lot of these drugs we don't use anymore, and that is probably largely related to this. All right, so which one of these meds actually get into the brain and do not cause inflammation and deterioration of the brain? So we have the privilege of an amazing research scientist at UC San Diego, and I think he's given lectures here for HARP recently over the summer. And he, with the help of naval recruits, has been able to do lumbar puncture studies and studying these drugs and finding which one get into the brain and which one do not. And over the years has compounded a table that I'll share with you in a second. But for each drug that gets into the brain, he assigns a score, and the higher the score, the higher it gets into the brain. And that's good in the case of Tivicay or dolutegravir or Emtreva, but it's not so good for abacavir or nevirapine. As I mentioned, those have been associated with some toxicity. So if you were to be, for instance, if you were taking Triumeq and you're on Tivicay, Epivir, and abacavir, your CPE score is going to be 4 + 2 + 3, so that's a score of 9. Well, that's a very good score. Anything above 6 has been associated with a decrease in dementia. The problem is the abacavir effect and the potential toxicity. And so that's why it's important to have knowledge of all these issues. So several trials have been done over the last 10 years. There was a large ACTG trial, which is an AIDS clinical trial group done by the NIH, that was recruiting for the sole purpose of measuring this CPE score and determining whether or not we can reverse dementia and improve dementia. The problem is that the trial could not be completed because not enough people enrolled. And part of the reason for that is, as I mentioned, is for a lot of people, this is asymptomatic. And unless somebody really asks you the questions and you find that you have some memory issues, and we'll discuss those in detail in a minute. This very busy slide is the table with all the different drugs, and I'll just point out the drugs with the highest scores because we all want to be winners. But as I mentioned, the first drug here is AZT, terrible drug. Nevirapine is a very good drug, and we still use it, but it has, it turns out, toxicity for the brain, so not great. This is Indinavir, Crixivan that's boosted, tons of kidney stones, skin problems, terrible drug. Newer drugs, fostemsavir, Rukobia, which is an entry inhibitor. It prevents the virus from getting into the brain, and it's very similar to Maraviroc, the cell's entry. Dolutegravir, Tivicay, which is part of Triumeq, and Dovato, and some of the older integrase inhibitors, and a whole slew of some of the older drugs that are completely not important at this time. But Epivir is right here. Emtreva gets into a little bit better. Doravirine, which is a new NNRTI called Pifeltrol, gets into the brain without causing toxicity. Efavirenz is the one that caused all the psychotic breaks and dizziness. But as I mentioned, H.A.N.D, the importance of H.A.N.D was also much higher in patients who smoke, who do drink too much, do meth or cocaine, psych issues, higher age, lower education, and CD4 and T cells less than 350. So everything is a moving, there's so many different cogwheels to take into effect. So it's very hard to definitely say, well, this is causing this and this is not, but you have to take it all together. conclusion also has been to always treat the HIV, and the reason for this is that prior to HIV therapy, we found that the median atrophy and thinning rate was about 1/4 of a millimeter per year of brain tissue, and that's your gray matter. This is the one that helps you think. So ever since we started HIV therapy, no further deteriorations or thinning of the gray matter has been noted. So how does it translate into plain English? What is it? How do you notice it? And it's defined as a reduced ability to think clearly. You know, getting lost is one of the extremes. One of my patients called me once and said that he had no idea where he was going. And this was pre-cell phone. And we had to just basically have a friend come and meet him at the intersection because he couldn't remember where he was going and how to get home. A more simple example is to, for instance, you're in the living room and you walk into the kitchen and you have no idea why you're there. You go back to the living room and you're like, I need matches or X, Y, or Z. And this is very subtle. Other thing that most of my patients complain about is difficulty remembering things, or, you know, what is that object in front of me? Oh, it's my glasses. Yes, I remember now. Or, oh, it's nice to meet you again, doctor. Oh, I forgot your name. Can you remind me? Or misplacing things like keys and phones and things like that on a repeated basis. And again, these are all very subtle, but usually picked up by family members and loved ones or colleagues, and it can be embarrassing. Changes in mood and behavior is also reported, but that's usually as you get more deeper into the dementia or the neurocognitive impairment. As I mentioned, it's hard to diagnose. Some of the things that also occur is balance and coordination, clumsy injuries, falls, burning yourself repeatedly, decreasing nighttime vision, missed appointments, completing tasks, not be able to, you know, complete your work if you're working, or getting lost at the supermarket, as I mentioned. All these things that I mentioned, and to some extent or another. What to do? Well, the recommendation is to alert your physician that, you know, some of this stuff may be going on. Is there something we need to do? Do we need to address the HIV meds that you're taking? And what I'm finding is that a lot of patients are taking medications, and out of the 3 drugs they're taking, there's only 1 drug that's actually working. And so you can imagine your scoring for the CPE score is going to be very low because there's only 1 drug working. And the chance of breaking through with HIV in the brain, also known as the dreaded escape syndrome, is very real. And we've done some work with Monogram, which does all the resistance testing, and they were able to do genotypes and phenotypes on spinal fluids, but not everybody likes to volunteer for a spinal tap to find out the hard way. Other things to consider is that we're all getting older, and simple things like family traits and diseases like Parkinson's or tremors or Alzheimer's can strike and have nothing to do with HIV. HIV is probably not helping, but again, we have to make sure we get a good neurologic evaluation to discern that this is HIV indeed and not something different. There are some new technologies with imaging and MRIs of the brain that have been helpful and can show selective brain tissue loss, and can help the neurologist so point out to the etiologies, as some of these things are fairly well mapped out. All right, what about other things that can cause infections in the brain? Well, syphilis, I think we're all very familiar with. And so don't underestimate the syphilis. You can have a negative RPR, but you may have had syphilis for 20 years and it was never treated, and your RPR goes back to normal, which is a very unusual phenomena. But most of us who treat HIV know how to look for this, and the spinal tap will certainly tell us the answer. Tuberculosis sometimes can cause these issues, but usually that comes at the price of high fevers, wasting, and you really don't feel very good. And with very low T cells, and a whole number of opportunistic infections and such can definitely cause and impair your memory and exacerbate the H.A.N.D. All right. second part of the talk, but perhaps we should pause here for a minute for discussion, or do you want me to continue? Guillermo?
You can continue.
Okay. Okay. So the other part of the routine maintenance care of HIV disease is making sure your bones stay strong and don't become brittle and sort of break for unclear reasons. And I'd like to give you an illustration of how the bone is really a living matrix. The bone is not just the same bone you had when you were 18. The bone is constantly being rebuilt, and we have bone-eating PacMen, so the osteoclasts of these little guys over here that basically eat the bone, and then you have the osteoblasts over here which make the bone, and it's a constant battle between these two. And it turns out HIV basically blocks the effect of the osteoblast and increases the activity of the osteoclast, so that you develop a bone deficit over time. The longer you are HIV positive without any therapy, the more bone density you lose. And one of the things that has really surprised us is that the bone density loss that is the most significant is actually the first year you take HIV medication, because despite the fact the HIV is no longer present because we're undetectable, the osteoclastic cells are activated by the immune system as a false signal. And there is a trial that's actually enrolling where they're putting new diagnoses of HIV on Boniva to really prevent this 20% drop in bone density loss. The rule of thumb is that within 5 years of HIV treatment, you may experience some degree of bone density loss and develop what we call osteopenia, which is mild in general and can be reversed with calcium and vitamin D. The longer you go, the higher the risk of developing osteoporosis, and that is when you start having increased risk of hip fractures or foot fractures, hand fractures, and that's when we have to resort to Boniva and Sally Field. Turns out in the setting of HIV, compared to the general population, there is definitely a lower bone mineral density than the general population. And in large clinical analysis, they revealed that there was 3 times as more people with osteoporosis and people with HIV compared to the general population. However, despite all of this, we've been struggling for years on what to advise and to whom on how to screen for osteopenia and osteoporosis. And the current recommendation is to screen all men over the age of 50 and premenopausal or postmenopausal women who are HIV positive. Men with in the 40 to 49 who have some family history or alcohol abuse or meth use are recommended to be screened earlier. I had a 26-year-old young man who had complete osteoporosis at age 26, but he also been HIV positive for 8 to 10 years and did not know it. And so he was sort of a exaggerated case, so to speak, but it felt funny to put a 26-year-old on Boniva. So what is causing this bone density loss? As I mentioned, it's a mixed bag. One other drug that comes up again is Variad, Truvada. There's been lawsuits against Gilead for not bringing the newer version of tenofovir to market sooner, knowing that this can cause some bone density issue. Curiously, in the PrEP trials, the Truvada didn't cause severe bone density loss like it does in the setting of HIV. So there's a compounding effect of HIV. And then other medications that have been incriminated did cause the bone density loss by affecting your vitamin D and causing very low vitamin D levels. And those drugs are Sustiva, Efavirenz, or Rayataz, Atazanavir. As I mentioned previously, alcohol use, methamphetamine, and opiate abuse also associated with a bone density loss. And then unfortunately, people who have to take prednisone for autoimmune disorders or lupus or any of those entities, prolonged course of cortisone with Medrol dose packs or prednisone can cause some bone density loss long term. And then finally, one that's often forgotten is those things that we get at Costco because we have heartburn called Nexium and Prilosec and Prevacid and Protonix. Also, the generic names esomeprazole or omeprazole have been associated with bone density loss and usually milder than some of the other drugs, but nevertheless can be, again, compounded by other issues. Hormones. What about hormones? Well, it turns out low testosterone in men is a problem. Low estrogen in women is a problem. We've known this for many years. Patients who have kidney disease or on dialysis will have a very high level of parathyroid hormones. So it's important when bone density is found to be low to rule out hyperparathyroidism, which is a simple test. And then finally, a diet low in calcium or phosphorus can cause sort of mushy bones and cause a bone density loss in that respect. And so it's a endocrinologic, kidney and immune system double whammy, so to speak. What about vitamin D? Well, there's a big craze to give everybody massive doses of vitamin D, but it turns out that if your vitamin D level is too high, that's bad too. But the commonly accepted normal range is over 30. I think over 70, you start to get into trouble. But below 30, 20 to 30, they recommend 2,000 units a day. Below that, then they really start to recommend 50,000 units once a week for 8 weeks, and then going up to the next regimen. But that usually corrects your vitamin D over the course of 3 to 6 months. Below 15, that it's probably time to really do massive dosing every day. So how do we look for bone density? We do a DEXA scan, and the DEXA scan is done, for instance, at Eisenhower at the Lucy Curci Cancer Center. It's also done at a couple of outfits in Palm Springs by the airport, I think Desert Imaging or Oasis Imaging or something along those lines. And it'll give you a number, and that number is what we call the T-score, and it's basically an averaging of your bone density compared to peers in your age group and tell you whether or not you're normal with a T-score of -1 or higher. Osteopenia is -1 to -2.5, and osteoporosis is 2.5. Again, don't need to memorize these numbers. Your doctor can do that for you. And we start basically medications only for osteoporosis. Osteopenia, we tend to go with calcium vitamin D supplementation, increasing exercise, increasing impact exercise. So going to the gym or lifting weight, all of that is going to help. If your testosterone is low, correct the testosterone. Again, that will help rebuild the bones. So the medications that are primarily used for bone density loss and osteoporosis in particular are things called Fosamax and Boniva. Actonel has sort of fallen in disfavor, but Fosamax is a once-a-week pill, and Boniva is a once-a-month pill. If things get really dire and we have to act quickly, we can also do Reclass, which is a once-a-year infusion, and there's a couple of other drugs called Prolia that can be given as well. And finally, if your bones are really breaking, there's a drug called Forteo that will rebuild your bones, and I believe that's daily injections, and that can be used in emergency. The problem with the osteoporosis is that once you get here, it is hard to reverse, and it takes many years to rebuild the bones. The drugs that we use, unfortunately, tend to cause heartburn, and that's why we ask you not to take the medication after you get out of bed, meaning don't go back to bed after breakfast, after you take your Boniva or your Fosamax. because you can actually develop an ulcer in your esophagus, and that's what we all try to avoid. The reclass sometimes cause flu-like symptoms. You can take Tylenol or Advil, usually takes care of that. Over the course of time, usually we treat osteoporosis for 3 to 5 years. And after 3 years, we start to worry about some of the downsides of taking these medications, because bone remodeling is not uniform and beautiful like a Venetian plaster. It's a little haphazard, and bone regrows in fits and starts, so to speak. And you can develop weakening of the shaft of your thigh bone, for instance, and develop some what we call atypical fractures. And that's not fun to deal with. Another curious and very terrible complication of these drugs is what we call osteonecrosis of the jaw. And that's mostly going to be present if you're doing any kind of invasive dental work, like a dental implant or a extraction while you're taking Boniva or Fosamax. So it's important you let your dentist know that you're taking these drugs if you are, so that you can avoid this complication. And what will happen, the bone around your tooth will die and lose blood supply, and you will have a chronic infection of your jaw, which then drains to your skin, and it becomes a huge mess to deal with. So the benefits of these drugs is not felt to be worthwhile beyond the 5-year, and is recommended that you stop these drugs after 5 years for the biphosphonate. Patients who have multiple myeloma or any kind of leukemias will have a much higher risk of this, so probably not a good candidate for these drugs. Dental extractions and radiation, as I mentioned already. Other things to do, don't rely purely on the medication, as I mentioned. I mean, removing the offenders, so taking the antacids away if you're able to, doing some exercise, weight bearing, good nutrition, healthy diet, and taking calcium and vitamin D. There's a commercial brand called Caltrate that combines the calcium and the vitamin D. There's several generics available. Otherwise, you just have to split it up. But the dose of calcium recommended is around 1,200 milligrams, and the vitamin D is 800 units or 1,000, whatever is convenient. Smoking, not a good thing. Alcohol, not a good thing. Limit all of the above and see if you can reverse the trend. All right. I will stop sharing my screen so we can take questions, if I understand correctly, right?
Correct. All right, so I'm going to open the conversation. So Brett, do you want me to read the questions on the chat? Okay, let me go. All right, so let's start here. Dr. Scott, okay, this is from Jeff Taylor. Dr. Scott Lettender and Ron Ellis have done a lot of important hand research over the past years at UCSD HIV Neuro-Behavioral Research Center. They screen people for their neurology and hand trials. And here's a number. So thank you, Jeff, for sharing that information. And there's a link there. Terry asked the following question: where does Epsicom fall? I found it blocked REM sleep and dreaming. Is this a known side effect?
Not offhand, not that I know of, but as I mentioned, the abacavir component of it has been associated with toxicity on the nerve cells in the laboratory. Again, it's a little hard to do these experiments in the live person because nobody wants to do a brain biopsy. But as Jeff mentioned, Dr. Laton has done a lot of research on this, and there's some concern about Epsicom and Triumec and any of the formulations of Epsicom for that reason when it comes to neurocognitive issues. So if there are some neurologic issues, I would maybe revisit that choice and use a different drug that doesn't cause these issues. The other drug that seems to be incriminated with causing agitation, confusion, and dizziness is Tivicay, also part of Triumeq or Dovato. Some people can tolerate Genvoya or Stribild or Icentris or Bictegravir, but cannot tolerate the dolutegravir. And as I mentioned here, that's because it seems to get into the brain a little extra well, and that may be the reason.
Okay, thank you, Doctor. Terry also asked, can you repeat the recommendations for osteopenia and how often one should have a DEXA scan?
So for osteopenia, the recommendation is calcium, vitamin D, so 1,200 milligrams of calcium and 800 IUs of vitamin D, or using Caltrate. And the frequency of testing is about every 2 years. Medicare limits any kind of testing to every 2 years unless there's a fracture. Commercial payers are sticking to Medicare guidelines for cost reasons. And the real reason is that bone density is a very slow moving entity, and it takes almost 2 years to see any kind of noticeable changes.
Good. Jeff Taylor is sharing an anecdote that says, I hear Epsicom abacavir can cause anxiety. Any thoughts on that?
Again, you know, I don't have any data on that per se. You know, I'm sure the multiple clinical trials with these drugs has listed anxiety, but you know, we're all anxious. It's COVID. It's monkeypox. It's
Yeah.
you know, there's so many things causing anxiety right now and give us agitation. But again, I'm not aware of that per se, but potentially the issue of the abacavir getting into the brain too well may be the issue. And as I say, everybody is different. Some people are more sensitive than others, and it's very hard to predict who's going to respond negatively to a drug. I always tell people, don't equate your friend's experience with yours, because you may have no problem and he will be very symptomatic.
Fair enough. Stephen is asking, can denosumab be continued longer than 5 years? My hematologist recommended chronic denosumab.
I'm not an expert on this denosumab. I think the recommendation is for the biphosphonates. So the drugs in the first class, the Boniva and the Fosamax are the issues after 5 years.
Okay, so those are the questions. Oh, there's more and more coming from Rick. Can you share your thoughts on mental exercise? For example, reading technical information, learning a new cognitive skill, etc.
Yes.
On cognitive impairment.
I recommend you all pick up Wordle. And if you think you're good, then go to Wordle, when you do 4 Wordles at one time, and switch to the hard mode, which forces you to use all the letters you've discovered, and you can't sort of put in guess for words. For those who don't know, Wordle is a thing in the New York Times every day, and you have to guess a word of 5 letters, and you have 6 tries every, I believe. But it's an excellent exercise, and you can do it in Spanish and French and Italian. You can just get it a little more complicated. And if words are not your thing, there's also one that does geography. And if you need things more geometric and sort of spatial, it's called Wordle or something to that effect. And it's the Wordle for the world. And it basically, you have to guess the country based on the outline of the country. But every activity that involves the brain. Am I still on the thing here?
Yeah, you still. I just opened the window to everybody.
Any type of reading or math or any kind of puzzle, Sudoku, all of those activities are great because they really force the brain to orchestrate the things. And one of the things I mentioned earlier is one of the drugs that has now become generic called Maraviroc or Selzentry. In clinical trials, and Dr. Letendre is the one that alerted me to this, they were able to show that in rats, If they remove the particular receptor that cells entry works on, the rats would forget where they would get their food, they would forget where their mates were, and once they reintroduce the cell entry into the rats, within a week or two, the rats went back to eating properly and going to the right place to eat and mating with their appropriate mates, suggesting that that particular part of the equation is crucial for memory linking. So the memory is there in your brain, is just that the HIV disruption prevents the cross-linking of hairs, if you wish, and reconnecting the memories together to form a concise memory.
Fair enough. Well, those are the questions on the chat. I will invite everybody to now participate if you want, using your microphone. Open your microphone if you have any questions for Dr. Gaultier.
Well, I like the, thanks, Jeff. That's a great,
Yeah.
the Brain Center. They do an amazing job. And again, I'm going to thank all our Navy recruits who are serving our military, who are HIV positive, who have volunteered for all of his studies for the last 15 years.
Okay, I have a question, Doctor, myself. I'm in Cambodia for a long time, and at one point my doctor took me off because some level of toxicity, and I'm back again because my viral load went up. So I didn't hear you mention it in your list of medications. So where do you stand with Cambodia?
So Genvoya has the drug, so it's Descovy and Elvitegravir and a booster called Cobocistat.
Mm-hmm.
And the issues with the Cobocistat, it tends to increase the level of other drugs you may be taking. So if you're taking anything for cholesterol or high blood pressure or for heart, there's a lot of drug-drug interactions. And for that reason, it's not a very favored regimen for that issue. Elvitegravir, I think, gets into the brain reasonably okay, but it's not fantastic. And I think because the Descovy, the tenofovir part, doesn't get into the brain, and then the Emtreva actually does get into the brain. So you're going to end up with a lowest score potentially. And then, as I mentioned, I would caution on making sure that all the drugs you're taking are actually working. And I've meeting a lot of new patients since I'm new to the desert who have been on the same drug for, say, 5 or 6 years. And it turns out they were resistant to 2 of the drugs 5 years ago when I contacted Monogram and got their old genotypes. And so this kind of stuff sneaks in, and it's sort of a slow progressive decline caused by this lack of potent medication in the brain.
Good. Another question came through the chat from Rick. Can you share your thoughts on COVID-19 infection impact on cognitive impairment in HIV infected people?
Well, I don't think there's data specifically on cognitive impairment in HIV specifically, but I will tell you that COVID has been implicated in gray brain tissue loss. And they did MRI studies of patients who had COVID 3 years ago and repeated the MRI 2 years later and showed that a significant portion of people had developed further decline in their brain tissue. And I can only imagine how this was compounded in the setting of HIV, especially if there's HIV breakthrough in the brain. So again, it's another call to make sure everything you're taking is working in the brain.
Cool. Any other questions? This is a great opportunity. We have a few more minutes to answer any questions. Fred, are you able to get the audio back for you?
I am. My
Okay.
phone died back. It's a tech day.
Okay, we have another question coming from the chat from Terry. Can you discuss VL blipping?
So blipping is defined as a viral load that's detectable above 20, but is below 200. The magic cutoff over the years has gone from 1,000 to 750 to 500 to 400 to now 200. And basically what we think is that a lot of these blips are explained by two things. One is drug-drug interaction. And for those of you who take a single tablet regimen that contains things like Tivicay or Biktarvy, you cannot take Tums or you cannot take your calcium at the same time. It does have a drug interaction. Other drugs where there's a lot of drug interaction is rilpivirine, so that's Edurant, that's Complera, that's Odefsey, and that requires a full acid stomach. And if you're not compliant with the full stomach, no antacids, and no Pepcid, and no Tums, and no Nexium, you're going to have some blipping. Making abstraction of the drug interaction, the blips are felt to be the following. It is a slow passive release of memory resting T cells containing HIV, which is then dumped into the bloodstream every 6 months, because these cells only turn over every 6 months. And you just happen to catch the slow release of these inactive, non-infectious, non-replicating viral particles. And that's why the recommendation is not to change therapy or to augment therapy. Many trials have been done to augment therapy in people, for instance, on Triumeq, and we'll add another drug. And they've done trials adding 5 drugs to people, and the blipping continued. It did not go away. So we feel that it's a non-significant issue if it's purely related to the memory resting T cells, and the magic cutoff is 200. Above 200, we start to worry that there is resistant, or as one often forgets, you can get reinfected with a new strain of HIV, which does have resistance. And if, for instance, you pick up Tivicay resistance or Epivir resistance from a new sexual exposure, you can and will have some blipping as a result. And over time, you may develop resistance to your other drugs.
Fair enough. Another question came, my doctor said my viral load went up because of the dead HIV. Comments on that?
Not sure what that means, but I think it's probably an illustration of what I described. But you know, the detailed analysis was that it's a non-replicating virus that is just being released passively by the changing over of the old memory resting T cells.
Okay, Jeff, thank you. Jeff is helping us in the conversation, posting links and additional information for everybody to check on the chat. Then we have a question from Len. My doctor increased my famotidine from 20 to 40 milligrams. Could this cause me issues?
Only if you're taking medications that the famotidine decreases the absorption. So the rilpivirine drugs, unless you're taking Cabenuva, which is injectable, where there's no effect of the antacid. But famotidine is pretty benign and may help with COVID, it turns out.
Okay, another participant. I have pretty aggressive osteoarthritis. Is this related to the bone loss issue?
No, so osteoarthritis, so bone density affects the whole bone and the shaft of the bone. Arthritis actually specifically refers to the joint space, and that's a completely different mechanism of action and pathology, and that can be, largely genetic. So not related to HIV.
Okay, last question here. Do those with osteopenia who lift heavy weights are at risk of bone fractures?
Yeah, so if you look at the results of your DEXA scan, there is a statistic and probability of bone fracture based on your result that you can refer to, but the answer is yes. With osteopenia, there's an increased risk of fracture, and it's important to do exercises that don't stress your bone in a weird fashion or at a bad angle, which could result in a fracture. But your doctor or your orthopedist should be able to tell you these things.